Welcome everybody to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for July 7th, 2022. This is the first one of our new academic year. I'd like to welcome our three new fellows, Dr. Dillon, Dr. Munir, and Dr. Patel. Hopefully you're on screen and you can wave. I don't know if we'll see you, but welcome. We're really thrilled to have new fellows every year, and you're safe to know you won't be on the wheel till at least January, so nothing to worry about. Just enjoy and learn until January 1st, when you can start vomiting before conference. Today's CME activity code is 485990. As usual, we have nothing to disclose. Patient confidentiality has been closely monitored. We change all the laboratory values, ethnicity and dates, etc., so that to really disguise the identity and of the patient and protect their confidentiality. We've got a great case today, Dr. Gashti. This is an interesting case, and I'm glad we have a good audience because this is going to be a tough one for us to sort out, and we're really interested in everybody's opinion. Anybody that's not on our mailing list, let us know. It's being recorded. It will be posted on our YouTube channel, and you can join our channel. And if you're not on our mailing list, just throw us an email or a chat, and we'll get you on the mailing list. And with that, I think Dr. Gashti is going to read us our protocol. Casey?
Yes. All right. The patient is a 23-year-old previously healthy Caucasian male who was referred to nephrology for evaluation of new onset hypertension and edema. The patient was well until about a month prior to his presentation, when he started to have headaches and noted to have peripheral edema. He went to Walgreens urgent care and was told his blood pressure was very high, and he was referred to his primary care physician. When he saw his PCP the following week, his labs showed an elevated creatinine of 1.2, almost 1.3, and urinalysis had significant amounts of blood and protein in it. He'd also been battling a 2-month-long sinus infection. He was started on Flonase, Claritin, and a course of Augmentin. Also of note, the patient reports he had an insect bite on the medial aspect of his right foot, which by the time that I saw him was pretty much healed and almost cleared. No history of sore throat, but sinus trouble for 2 months that has not been relieved by the above medications. He has no history of illicit drug use or cocaine use and no NSAID use. He reports that he had tea-colored urine for the past 2 days. When I repeated his labs initially, 2 weeks after he saw his primary care physician, his serum creatinine had already risen from 1.3 to 2.9 milligrams per deciliter. His blood pressure was also quite high, so I started him on nifedipine for blood pressure control, and a renal biopsy was scheduled. As you can see, he doesn't really have a lot of medical history. He had seasonal allergies. He had a minor thumb surgery after injury during sports. No family history that's significant, never smoked. He drinks pretty regularly, mostly beers, but also cocktails, occasional marijuana use, no family history of autoimmune or renal diseases. His medications were sort of transient and temporary Claritin, Augmentin, and Flonase, all of which were just added recently, but it was prior to the onset of his symptoms. I'm sorry, these were started after the onset of his symptoms. Allergies, no known allergies. Review system was only significant for the tea-colored urine, sinus congestion, bilateral low extremity edema, and headaches essentially every day. His blood pressure was 165/95, heart rate of 82, respiration is 12. He's 210 pounds and he's 6 foot tall. His BMI is 27. He appeared pretty non-toxic. His heart and lung exams were unremarkable. He did have 2+ bilateral lower extremity edema, and he did not have any skin manifestations, no rashes or bruising. His neuro exam was unremarkable, and he had no lymphadenopathy. His labs, sodium was 139, potassium was 5, bicarb 24, BUN and creatinine were 26 and 2.7 respectively. His total protein was 5.2, his albumin was 2.3, calcium, corrected calcium was 8.4, T-bili, alphos, AST, and ALT were normal. His white count was 7.3. His hemoglobin was 12.9 with a platelet count of 290 and a normal differential. ANA, double-stranded DNA, and complements were normal. His ANCA and anti-GBM at the time of the biopsy were still pending. His viral serologies were negative. This is an older case. At the time, COVID was not around, so there is no COVID testing here. Coags were normal. Urinalysis showed a large amount of protein, cloudy dark urine, specific gravity of 1013, pH of 5.5, negative ketones, Billy, large blood, 60 WBCs, more than 200 RBCs, with 5 squamous epithelial cells and 26 hyaline casts. His urine protein to creatinine ratio was 8.3 grams per gram. His SPEP and UPEP showed no monoclonal immunoglobulins. His renal ultrasound was normal, and a renal biopsy was performed.
So, Dr. Gashti, he has this history of hypertension and his creatinine is 1.3, and he arranges to see you, but what made you think to get the labs before you saw him?
I didn't. I saw him first, and during the visit, I repeated his labs. I wanted to see what his creatinine was. His blood pressure was clearly high. He had edema. So I got these labs after I saw him.
I see. Okay. And it obviously had doubled it or whatever at that point.
The creatinine had doubled. He had an active urine. He had a urinalysis from his primary care at the original visit because of the hypertension and everything. It was actually very astute of her to order a urine test because of hypertension in a 23-year-old, otherwise healthy person. So that was good. So I had 2 UAs and both of them were active.
It is good because, we take it for granted as nephrologists that that's part of the workup for hypertension. But it's not, unfortunately, always the case. And for all you know, you get a patient sent to you for either uncontrolled high blood pressure or just
edema,
mildly elevated creatinine 1.3 when this, at least clinically, it appears to be a much, much bigger picture than that. So, yeah, I mean, it seems like that should be what's ordered out there in the real world, but it's not. It's just like when someone comes to the ER with flank pain and hematuria, they just assume it's a stone, and no one kind of expands the differential diagnosis to maybe GN. So, kudos to the team that sent them to you. And so you started the patient on steroids and then arranged the biopsy.
Correct. Well, the biopsy was pretty immediate. Yeah, I mean, he came to the hospital and we biopsied him right away and started him on a steroids that day.
All right. So before we have this case discussed, let's run a poll here. I want to see what people think. What's going on? So this is our first poll. What do you think this patient has? An infection-related glomerulonephritis, granulomatous polyangiitis, IgA nephropathy, anti-GBM related GN, or acute interstitial nephritis? I don't want to bias people too much, but Dr. Gashti's nickname is Dr. Interstitial Nephritis. So now I'll watch that suddenly surge in the numbers. But he is the king of interstitial nephritis, and the patient I think did receive antibiotics, so he had this chronic sinus infection. So it's an interesting.
Would never rule it out with Casey.
You never rule it out with Dr. Gashti. Exactly. Augmentin. Please vote. No one will tell on you. Getting a nice response here. Let it go a little bit longer.
Yeah, 10 more seconds here. See if we can get some more people. All right. So I will end the poll and then we'll be able to share and see what the audience thought.
So 20% thinks it's an infection-related GN. 40% think it's granulomatous polyangiitis. 28% says it's IgA nephropathy. 12% anti-GBM disease. And boy, nobody bought acute interstitial nephritis. After all that, I'm really shocked. Well, we could be in for a surprise. We'll have to see. Bill, you want to tell us your thoughts? What did you vote for, and what are your thoughts?
Yeah, I probably wouldn't have AIN on there just because of the urinalysis findings, but there's about, I don't know, 15 different ways we could go with this case. There's just so much here. I mean, we could take it from a young man who's got URI symptoms with gross hematuria and proteinuria. There's a whole differential there. You could have the differential of an RPGN because he clearly has really, really significant AKI with active urine and a lot of proteinuria. You could take it into this infectious route with his recent bite and his URI, or you could even do the workup for nephrotic syndrome with AKI. So it can go in a lot of different ways. And I think each one kind of deserves a little bit of discussion, but since it's so much, I'll try to keep it as brief as possible. But if you think about a young man from the first line with hypertension, edema, tea-colored urine, sinus infections, active urine, you're thinking about IgA nephropathy. How often does IgA nephropathy come in also with this much nephrosis, AKI and RPGN? Well, crescentic IgA nephropathy exists. IgA nephropathy with focal sclerosis can be also part of the nephrotic syndrome there. So I think that's a big part of it. And IgA is always high in my differential when it's a young man with normal complements and we have gross hematuria. So that's definitely up there. It's typically a synpharyngitis and not sort of a longer lasting one, but it could still happen. Speaking of the pharyngitis or the URI symptoms, we would have to think about GPA, and the ANCA is pending. We've got a bad AKI with what seems to be an RPGN, and a GPA meaning granulomatous polyangiitis. And they often have upper sinus involvements, even if they don't have, alveolar hemorrhage. So I think that's high in the differential. The ANCA pending may just be a little teaser, or it's probable that it just hadn't come back in time and we actually got the biopsy first. ANCA and GBMs are sometimes take a while. We could, when somebody's this nephrotic and they're nephritic, I always would put MPGN on the diagnosis. The other one that I think about with nephrotic and nephritic is a collapsing FSGS, and both of those can give AKI. And then could it be good old-fashioned post-strep or post-infectious IgA related from a cellulitis of his skin? I think those are possibilities here as well, but typically, a post-infectious GN is not going to be having, I don't think it's going to be this aggressive with an RPGN. And if it is a post-strep, I mean, it'd be pretty unusual to have normal complements, I think. So there's a lot there, and thus the poll had all those in there. So I'm glad that I think I hit most of them. I probably wouldn't think that much about GBM disease in this case, but it's always something to think about with any RPGN. So I guess my number one, putting it, if I had to put my nickel down, and it's definitely not my top 10, but number one would be IgA nephropathy. Number two would probably be a GPA. And then number three would be maybe an MPGN or even infection related / MPGN C3 kind of thing.
So, Bill, I know you know this because you've given lectures on MPGN, and I know that MPGN isn't a disease anymore; it's a pattern of injury. And so, when you say MPGN, why don't you give us some clinical, little differential diagnosis other than just a pathology?
Yeah, sure. It's it's really driven by the pathology, specifically the immunofluorescence gives us a little bit more guidance as to the cause of the MPGN pattern of disease, but yeah, a lot of times it could just be something. If the immunofluorescence is negative, you could think about it as it's sort of an ischemic renal disease that you would see in sickle cell disease or even malignant hypertension. If the immunofluorescence is positive for C3 alone, then we think about C3GN or possibly post-infectious related MGUSs and myelomas and monoclonal gammopathies can give rise to an MPGN pattern too, and light chain restriction would give us the guidance there. And then autoimmune is always in that differential too, with lupus and or even infection related ones where it's not just the C3, but it could be a full house pattern. So really the immunofluorescence is the huge guide to that. And so if you only got one glomerulus on the biopsy, you're definitely going to want to send it for the IF if you're thinking MPGN is the pattern of injury.
So there's not a lot of those you mentioned that really kind of fit his picture.
The reason I was sort of bringing it up is because it is often nephrotic and nephritic.
No, I think you're absolutely right. I just wanted to point out that, I know of course, it's just, it's not we're trying to get away from pathologic descriptions, but I think it's still important because we get that back, and then as clinicians, we have to take the next step and go to immunofluorescence. And, we've all constantly refer to that algorithm in the New England Journal of Medicine article. Must be 10 years ago and by now, but which breaks it down by the immunofluorescence staining and the like. So yeah, I think you're right. It's kind of a nephrotic AKI picture, and there's a lot of things in that differential. Dr. Glassick, you put something in the chat, but I want you to elaborate on it for us, please.
Yeah, can you hear me okay?
Sure can.
Perfect.
Yeah, well, I put in the chat room that my first impression of this case would be infection related for several reasons. One is hypertension is not a very common presenting feature of crescentic GN. And nephrotic syndrome, which the patient has, is also very atypical. So I would not be suspecting a crescentic GN. Now, IgA nephropathy is certainly a possibility, but uh, in this case, with the lack of gross hematuria, microscopic hematuria only, and the I wouldn't say hyperkalemia, the tendency to higher potassium suggests the possibility of volume expansion and hyporenanemia, which is the feature of infection-related GN rather than IgA nephropathy. But obviously at this age and with onset of hypertension and hematuria, IgA nephropathy has to be considered, but nephrotic syndrome only occurs in about 10% of patients presenting with IgA nephropathy.
So,
Anyway, that's
when
my
you
2 cents.
well, I appreciate that. So when you say crescentic GN, hypertension is not that common. What do you mean by crescentic GN? Are you talking about vasculitis or just anything with
Yeah,
crescent?
vasculitis,
Okay.
ANCA positive or anti-GBM, either one.
Okay. Yeah, I called Bill out on using a pathologic term. I guess I get to call you out on using a pathologic term. Please forgive me. Anybody else have any thoughts? Mario, Dr. Rubin, what do you think this patient has?
Well, as Bill said, I think he has an RPGN. And the sine qua non pathologically of RPGN is the presence of crescents. And as it was stated, immunofluorescence is key. And what I have taught every time I get a chance is what Bill Kauser, who is known to a large majority of the audience here, he published a key paper many, many centuries ago on the immunofluorescent approach to RPGN. In those days, the serology took its time to return, so it was very helpful. And based upon that, he classified in class 1, 2, and 3, class 1 being anti-GBM, class 2 being immune complex, such as IgA, as he was discussing this case. And class 3 was the post-immune, and that one, in those days, we didn't know much about ANCA, but later on, it became, the approach was ANCA positive or ANCA negative, and that is extremely helpful, that classification still today. So I would encourage the young trainees to keep it in mind. And what do I think? With all due respect to Dr. Glassok, I personally think this is a crescentic GN and the immunofluorescence is key. On the side, the paper, Roger, you quoted in the New England Journal of Medicine, I think by Fervenza and Seppi on MPGN, missed the fact that there are MPGNs with a pattern of injury which does not have a positive IF. And those are transplant glomerulopathy and TMA, which we need to remember. That's about it, and I apologize, but the gardener has shown up.
All right, well, tend to your garden. That's always important.
Yeah, there is that whole immunofluorescence negative sort of vascular MPGN pattern too, and it's important to remember sickle cell described with that as well. And another thing about this case, is that the post-strep often will come in looking with significant apparent fluid overload, but often the absence of nephrotic syndrome. So I didn't bring that up because we had nephrotic syndrome here, and his albumin is actually low. But that's one of the genes I think about when you look like you're expecting there are going to be a lot of proteinuria, and then you see the urinalysis actually doesn't have that much. This apparent fluid overload in post-strep.
Yeah, it's
Fluid
very
overload,
high.
not from nephrosis.
Yeah, very high renin state. Congested glomerulus, high renin state, and that's why the kids can present with such hypertension and even pulmonary edema from their hypertension. And one of the things I was taught a long time ago is that of the differential diagnosis of acute congestive heart failure in the elderly, you should think about a post-infectious or a post-strep GN. That's often how they present. That the system that Dr. Kauser described that Dr. Rubin had brought up, that was what the prevailing system was when I was a fellow. It was all based on immunofluorescence, linear, granular, or nothing. And everything keeps changing in nomenclature and serologies, and it's kind of a Venn diagram still how you want to look at it. And I think that each of these have been pretty well discussed. I'd like to say parenthetically that Bill Kauser was Dr. Lewis's, Dr. Ed Lewis, who trained us all. He was Dr. Lewis's very first fellow. So kudos to Bill and kudos to Ed for two amazing careers. I think if anybody else has any thoughts in the chat, we have some thoughts about spider bites and MRSA and infections, and I think that's interesting too. But I think it's time to spin the wheel and see who's going to read the biopsy. Okay. Great wheel. Teach us once again with your wisdom. Who should read this biopsy? Well, I don't think Casey's going to read his own biopsy. Kelly?
All right. Kelly.
Kelly's one of our newest second year, not a new fellow, but now second year fellow and chief fellow extraordinaire. So there's not enough pressure for you, Kelly.
You should be able to unmute yourself, Kelly, now. Go ahead and test your audio.
Can you hear me?
Yep. I'm going to give you control here. Give me a second. Go ahead and click on the screen. Perfect. You're controlling it. Go ahead and move that. And you can move yep. I'll let you control the slides. Remember, there's a lag.
Can you hear me okay, Pravir?
Changed it up this
Yep.
year. Where's the magnifying glass?
I have both. Don't worry.
Oh. Oh, there it is. Okay. So the first slide here is showing one core biopsy. It seems to be a pretty good sample. I do see what I think are glomeruli throughout. This is the trichrome stain, and here we're looking for chronicity. I don't see much blue staining material actually, and the tubules overall actually look pretty packed together. I don't see a whole lot of interstitial infiltrates. Looking at the glomeruli, there may be some scarring, maybe like here. I think this is a glomeruli, maybe some scarring here as well.
We'll wait for a higher power.
I mean, yeah,
It's hard to analyze the gloms at this low power, but I agree with everything else you said about tubules and interstitium.
Sometimes at this low power, you can get a sense that there's a lobular pattern there or not. Sometimes even easier here. Do you get that sense here since MPGM was in the differential, Kelly, or no?
It's kind of hard to tell, to be honest. I'd like to see a higher power. They look full. The glomeruli look full, like with lots of cells, but I don't think I can tell quite yet. Okay, moving on. Okay, so here we have a higher power. This is an H&E stain. Right away, I see 4 glomeruli here. I'm going to focus attention on this one first. This almost looks like, so it looks like it's almost like scar. There's a lot of inflammation, a lot of cells. I don't see any open.
Yeah, you know what,
loop.
Kathy?
Is this
Kelly,
glomerular?
start with the glom to the left of it.
This one?
Yeah.
Okay, this is a crescent here.
Yeah.
Okay. And I see very few, I don't really see almost like any open loops, but definitely a crescent, definitely some mesangial hypercellularity. And then,
Yeah,
Yep.
right. So 3 out of these 4 glomeruli have cellular crescents. So the one on the far right, bottom right, that's mostly parietal epithelium. All those cells, yeah, that's all crescent. Glomerular tuft is probably compressed in the middle in there somewhere.
okay.
Yeah. And then the one, if you go up to the top, yeah, you could see a good crescent there occupying most of the urinary space. Yeah, if you trace that around all the way around to the top, yeah, that's all cellular crescent.
Okay.
And then the tuft is in the middle.
Yeah, okay, I see what you're saying. And this is the tuft right here.
Yeah.
Okay. Got it.
You know,
And
Kelly,
then what
when,
about, sorry, go ahead.
when you have a glomeruli this really this full of cells, it really is difficult to sometimes see the architecture. And once we get to a PAS or a silver, it becomes really, really quite clear.
Yeah.
You said mesangial hypercellularity. I don't know that I would be able to tell you what's going on, other than the capillary loops aren't open and they're full of cells. We used to call this endocapillary proliferation. Now we call it just hypercellularity, because we're not sure exactly what and where those cells are. But I think you pointed out the important things: crescents and a very diffuse proliferative GN.
Yeah, and then also interstitial nephritis.
Yeah.
You can see infiltrates of cells surrounding the glomeruli there as well. Yeah.
Is the infiltrate actually in this glomerulus, or is it just outside? Or what is?
Yeah, that's in the interstitium.
This is still in the interstitium.
Yeah,
Okay.
yeah. That one glomerulus there does not have a crescent.
Okay, that's what I was going to ask. Okay, perfect. Yeah.
David, when you see this interstitial nephritis around a glomerulus, and it's probably reacting to the glomerular inflammation. It's not the interstitial nephritis we typically think of related to an independent process. Is that fair?
Yeah. I agree. Yeah, I mean, here we have crescents and necrosis, so probably related to all this severe glomerular inflammation.
Okay, so here we have a closer up view of one of the glomeruli, H&E stain again. So looking at this would be just the tuft right here, and then actually it's just really full of cells. So maybe, okay, so maybe this is part of the parietal epithelium here, and maybe it's like on its way out. It's kind of hard to tell like when the parietal
Well, yeah.
stops.
It's a crescent. You have a cellular crescent. In fact, down at 5 o'clock, what do you think that bright pink material
Okay,
is?
this is fibrinoid necrosis.
Yep. Yeah.
And-
So it's a very active lesion, and the glomerular tuft is compressed in the center, but it looks, like you said, very hypercellular, full of nuclei.
Yeah. And then again, you see the infiltrate kind of outside of the glomeruli.
Yeah.
Yes.
Yep.
So David, I have a question for you. The tubule at about 7 o'clock looks to me that it has areas that I would call tubulitis. I see some halo sign in some of those cells, which leads me to the following question. This patient was taking augmentin. How can you separate an AIM due to augmentin in this case, superimposed on the GN that we see, versus an interstitial infiltrate just being the extension of the glomerular process, particularly in the setting of tubulitis?
So those are all tubular nuclei. There's no lymphocytes actively in the tubules there. So that's all part of ATN, sloughing of epithelium. I don't see any active tubulitis.
Okay, well, I wish I could have a pointer to show you what I'm talking about. Okay, that's fine. Thank you.
Okay. Oh, going too far.
Oh, okay.
You-
Sorry, my computer is lagging.
Yeah, go back a few.
Okay.
One more.
Okay.
There we go, right here.
There we go. Okay. Okay. So here we have a close-up view of another glomerulus.
Actually, a 4, right?
Yeah, sorry. My computer's just like totally lagging on me. Okay, yes. I'm on the right slide now. Okay, 4 glomeruli, still H&E stain, and here we're just visualizing 4 glomeruli with crescents all undergoing active inflammation. So
Yeah.
crescents.
So the biopsy had 21 glomeruli. All of them have cellular crescents, as we see here.
Perfect. Okay.
So yeah, widespread crescentic glomerulonephritis.
All of them, David?
Yes.
21 of 21.
Yeah.
Wow.
Wow.
Yeah, now we'll
Well,
see, yeah, either crescents or necrosis. So we'll see some portions of tuft, like on this next slide, where it's an early necrosis, but all of them had some degree of necrosis or crescent.
David, were all the crescents in the same stage of evolution?
Yes.
Thank you.
Okay. So hopefully I'm looking at the same slide as everybody, but this is one glomeruli in the or glomerulus in the center, H&E stain again. And is this like maybe I mean, it's very hypercellular again,
Yeah.
but no crescent yet.
Well, yeah, up in the top right, the
Here?
parietal epithelium starting to rev up. Yeah.
Okay. Yep.
Yeah, it's not a crescent yet, but it will become one. But on this power, what kind of cells do you notice are within the glomerulus?
What kind of cell? Oh, okay. What kind of white cells? I'm trying to look to see. So I think like they're multi lobed nuclei. I'm trying to find
Good. Yeah. Where the arrow is right now, that's a neutrophil. Yeah. So there were a few scattered neutrophils, and then if keep over going to the arrow to the left and up a little bit. Yeah, over the left. Yeah, second one, and then up to the left slightly. There's a third neutrophil. Yeah, another neutrophil there. Yeah, so a couple of glomeruli had some scattered neutrophils. And over that, like at 9 o'clock, there's a lot of endocapillary proliferation. You could see the loops completely occluded by cells. If you keep going, yeah,
very
there, and keep going down. Yeah, that segment there.
Yep.
Yeah.
So David, would you call this at this point an exudative GN lending support to Dr. Glassock's diagnosis?
I would, like I said, there is rare to scattered neutrophils, but it doesn't make kind of a characteristic or classic case of exudative glomerulonephritis on the histology.
Okay, so this next slide is the PAS stain. It's showing one glomerulus in the center. We have the hilum that we can visualize here, maybe the macula densa here, perhaps. But right away, we can see that the tuft is more collapsed in, maybe like the start of a crescent over here.
Yeah, over at 9 o'clock.
Yep. Yeah.
Okay, yeah. There's a lag on the arrow.
Yeah. Sorry.
Yeah,
And
how about a lobular appearance? Not so much. Yeah.
not so much.
Yeah.
It just looks kind of collapsed in on
Yeah.
itself.
Oh, you-
I guess
what-
I don't know if I should say that.
Yeah,
but-
yeah, it's full, like up in the top section, it's full of nuclei. So I think, yeah, you would think it's collapsed, but actually it's hypercellularity proliferation filling all the loops.
Okay.
Yeah, so it's not really ischemic or collapsed, but just full of
Full
proliferation.
cells. Got
Yeah.
it. Okay.
And then go back.
Okay.
Yeah, so you could clearly see here, like up around 2-3 o'clock, the lymphocytes are all in the interstitium. But Dr. Rubin, you could see there's no, active tubulitis, in the surrounding tubules. They're all tubular nuclei.
Okay. Here we have the silver stain, one glomerulus that we're looking at. So here we're mainly looking at the basement membrane and seeing if there are any breaks in it. And I would say yes. I would think that there's maybe a break over here. I don't know if I'm lagging, but kind of over 8, 9 o'clock, maybe the start of like the parietal cells proliferating. But yeah, kind of all over on the left side, like 8 to 10 o'clock, the basement membrane looks like it's broken. And then definitely some fibrinoid necrosis as well, in kind of in the 11, 12 o'clock area.
Yep, good, Kelly. And then on the next slide, we have an uninvolved glomerulus. So you could see, what the basement membranes, if we suspected it MPGN, we would see double contours, and we really don't have that here. Yeah, smooth basement membranes.
Okay, so here I think, so we're going back to a PAS stain. So here we're looking at all the tubules, and I think we're just kind of trying to demonstrate here probably that there's ATN as well, sloughing of the tubular epithelium. You can see
Kelly. Yeah.
Is there anything else to add besides just ATN?
Yeah, sloughing, loss of brush border, and then as the epithelium regenerates, you start to see mitotic figures. And if we go to the next slide, you see a tubular mitotic figure somewhere there.
Right here in the center, basically.
Yep.
David's always nice. So you could cross the screen and you'll find it. It puts it exactly in the middle.
Yep. All right, so now immunofluorescence.
Now immunofluorescence. I think this is positive for C3. Yeah, pretty.
Yeah, so then it's a strong staining. And then where do you think, Kelly, mesangial or capillary wall or both?
Probably both. I would think it would be kind of hard to tell just because because you have a lot of endocapillary proliferation as to, like, I'm just thinking back to the other slides. But I mean, I guess over here.
Yeah, that's definitely capillary wall there.
Yeah, capillary wall, and I would say probably mesangium as well.
Yeah. Yep, I agree.
David, is that a big hump at 9 o'clock?
This.
That's probably it's probably too big for a hump. You know what? Go over to like 3 o'clock, and go down. Yeah. And keep going down. Yeah, that might be a hump there. Typically humps are like of that size.
Okay.
I think that's like a whole cell that's staining, because that's the size of like a nucleus or even larger. So, humps are much smaller than that.
Oh, okay. Okay, IgA is negative.
Yep.
IgG is negative. IgM is negative. Okay, and then our stain for fibrin is staining brightly positive. So these are glomeruli here and then here.
Yeah, so it's staining these necrotic areas, like on
Okay.
the left, there's a circumferential crescent with fibrin intermixed. You can see the tuft in the middle is not staining, and then where the
Okay.
arrow is now, there's a little pocket of necrosis.
Okay.
Yeah.
Okay, moving on to EM. So to get oriented, here we have our endocapillary space, basement membrane, podocytes here, and then urinary space out here. So it looks like I'm looking around the basement membrane for any deposits and electron dense deposits, and I don't see any. And the podocytes actually look pretty good. They don't look effaced, at least where I'm looking here.
Yeah, I agree. Yeah, we don't have the characteristic large humps in this image.
Oh, shoot, I think I might have.
Go back one.
Yeah, sorry.
There you go. Right this one. Yep. Just give it a second.
Okay, there we go. Okay, so in the center, we have our endocapillary space, basement membrane, and then urinary space out here. And so again, looking for any electron dense deposits within the basement membrane. I do not see any. And then looking at the podocytes, maybe like some, honestly, they look pretty good, but maybe some like focal effacement, maybe like here, and maybe I guess over here, maybe some effacement.
And it looks like up at 12 o'clock, we have some small little scattered mesangial deposits. Yeah, in there, some of that electron dense material there. But yeah, very focal scant deposits. No humps, like you said.
Billy, let's just go on and let's go to the diagnosis slide.
Okay.
Yeah, there was some small mesangial deposits there at 9 o'clock. Yeah, but no humps.
Okay.
Same thing.
Okay.
Yep. Okay, so we have percentic GN, all the we have percentic GN that stained positively for C3, so percentic C3 glomerulopathy. Percentage GN. I mean, for
yeah,
sure.
and in the clinical setting of positive ASO and infection, it's likely infection related GN is what I would say.
Okay. Okay, interesting.
So before, infection related GN without humps, but we're going to have a poll here now before we see what other people really think about this, because given the pathology in the story, and a lot of it depends on how you interpret that final diagnosis. How would you treat this patient? Number one, nothing. This will resolve on its own. 2, RAS inhibition alone. 3, steroids with or without RAS inhibition, or steroids with immunosuppression with or without RAS inhibition.
Getting some good responses. give it 10 more seconds here.
Melanie writes in the chat, this is a hard poll question. I think that's the point, the point of this conference, and it's the point of the poll.
All right, let's see what people thought. Last few, end the poll here and share.
So about 20% said nothing, and then I assume they're thinking this is post-strep, and that's kind of self-limiting. I got RAS inhibition alone, kind of same thing as number one. Steroids with or without RAS inhibition is the winner at 54%. That's a little surprising to me. And steroids with immunosuppression, 23%, probably going more along the crescentic pathway. Bill, what do you think this, quickly, what do you think this patient, how do you put this together clinically? What diagnosis would you give this patient?
I think an infection related or post-infectious does make sense. The problem with that is that I don't really believe that exists. And kind of like hypertensive nephrosclerosis doesn't exist. I think a lot of these patients may have underlying complement pathway problems, and it may be something like that, but that would be hard to do. I do say that when you see crescents though, and it's an RPGN, I can't even imagine not treating it, even though post-infectious is supposed to be self-limited. This many crescents with AKI, RPGN, in my mind, has to be the kitchen sink, and I would do a Cytoxan and IV Solu-Medrol and steroids.
And Dr. Glassick, how would you put this together? What do you think this patient has?
Well, I'm not sure. The pathology is compatible with C3 glomerulonephritis, although the absence of subendothelial mesangial deposits by EM makes that unlikely. The absence of humps is sort of against post-streptococcal GN. I think this is still in the realm of infection-related proliferative and crescentic GN. It's definitely not an aposi-immune crescentic GN or an ANCA vasculitis, I don't think. I would probably give steroids for a while. I don't think I would add cyclophosphamide or plasma exchange, not at this moment in time, but this is really a puzzling case. I'm not sure I have any clear idea what the best therapeutic approach would be.
Yeah, I think you have to put a lot of weight on, I mean, the C3 is the big find. Crescents with C3 is the big finding there, and you're kind of left with, there's something missing for everything, and I'm not sure where you're gonna put your nickel down. I think Mario asked a really important question at one point, and that was, to me, what stage are these all in? And they all the crescents seem to be juicy cellular crescents, which may have a prognostic factor as well. And a lot of some of the AKI could be ATN, some of it could be the crescentic GN, some of it could just be a glomerulus completely plugged up. And so, I don't have really any idea what the prognosis is going to be here. For me, I'm kind of with Bill. I see this many crescents. It's hard for me not to give cyclophosphamide once I've ruled out endocarditis or something else, which we always have to do before we give any prednisone for that matter. But yeah, I don't know. It's not IgA nephropathy. We know that. And I think it's, Bill alluded to the spectrum of hypocomplementemia and post-strep GN and I'm sorry, and C3 GN, and kind of an overlap. And we'll have to see what Dr. Gashty thought. I think for sake of time, Casey, you want to take over?
Yeah, I would. So as I mentioned, this is a little bit of an old case, so I actually have some follow-up with this. At the time when we saw this case, this is about 9 years ago, C3GN was being mentioned, but it wasn't as predominant of a diagnosis. So we with the history of this recent infection with the sinus issues going on for 2 months, and the light microscopic finding, the fluorescence C3, those 3 out of the 5 criteria that are usually used, this patient did not have hypocomplementemia, which is unusual, and also didn't have hump. But I think that finding a hump on EM is a little bit of a operator dependent process. If you don't scan enough area, you may miss a hump. I mean, on fluorescent, we may have seen a hump on one of those spots, but maybe on the EM, we didn't find it. So that one to me is a plus minus. But we basically approached this as a case of a post-infectious glomerulonephritis, and the ASO titer was, the ASO antibody level was quite high in this patient. So that also added a little bit of a data point that made me think maybe this is post-infectious. But because of how all 21 gloms were involved with either crescent or necrosis, we did go ahead with both steroids as well as Cytoxan. And as I will show you in a slide that's coming up, he actually ended up doing pretty well with this. I know that there's been this spectrum of C3GN versus post-infectious. I found this slide to be very helpful in sort of differentiating when you start thinking about a C3GN, because a lot of articles are talking about how C3GN is really masquerading as post-infectious, and there is no such thing as post-infectious. There is, especially in the pediatric population, the typical post-infectious GN, where you get an infection, you get a GN from it, and then you recover, and it's usually self-limited, and the complements sort of go back to normal. If you look at the complements here, this is the yellow circles are complement factors, the red triangles being sort of the complement regulatory proteins. When the complement level gets activated, you do recover pretty quickly. In cases of either atypical post-infectious glomerulonephritis, which is a terminology used for patients who get an infection-related GN, but they either are slow to recover or the amount of proteinuria and hematuria persists beyond the 6 to 8 weeks that you expect the complements to normalize, then that becomes a little bit of an unusual or atypical presentation. And that's when you really start having to think about, does this patient have a complement regulatory problem? And is that what's kind of, has that been unmasked due to the stress of recent infection? And from a histologic perspective, the big differences between the C3GN and a post-infectious GN is on light microscopy. MPGN is usually the pattern in C3, whereas an exudative diffuse proliferative GN would be the pattern in post-infectious GN. Of course, there's quite a bit of an overlap in these, but if this is helpful on the biopsy, it may add to whether you think this is C3GN or not. And on fluorescent microscopy, usually C3 is seen in both, but in C3 usually there are no other immunoglobulins, whereas you can have co-deposition with some pattern, either IgG or IgM in C3GN. And as Dr. Glassick mentioned, subepithelial humps are typical features of post-infectious, whereas usually subendothelial or mesangial or even sometimes intramembranous deposits are features of C3GN. So this case has a little bit of both, so it's still not really very clear. And they all, the cases where they become atypical, they persist beyond a few weeks, they all kind of deserve looking at a complement cascade, and usually it's the alternative complement pathway. Looking at these are 11 patients that were studied at Mayo Clinic. They all had atypical post-infectious course, meaning that they either had persistent hematuria, persistent proteinuria, or they had hypocomplementemia beyond the 8 weeks or 2 months post-GN. And 3 of them had, out of the 11 patients, 3 of them had mutations in complement factor H. A whole bunch of them had C3 nephritic factor issues, and some of them actually had mutations in complement regulatory proteins. So we basically have to look at the complement pathway. This patient received Cytoxan and prednisone. This was in 2013. He recovered kidney function down to about a creatinine of 1.5. I didn't really, treat him as a C3GN. I didn't put him on Cellcept for the rest of his life type of stuff. I put him on just losartan, and his creatinine has basically been, this is the latest I saw him a few months ago, his creatinine is about 1.5. So he's got 9 years of follow-up without any immunosuppression beyond the initial induction treatment. And he's done pretty well. One of the puzzling pieces of his case is that his ASO titer never really went down. He started at 350. He even had in 2016, it was 550. So he has this persistent elevation in ASO antibodies. And I'm not really sure. I mean, there are articles that talk about how that could be an indication for tonsillectomy, but he's a young kid. He hasn't really had any issues since then. His proteinuria, has gone down to essentially a microalbuminemic range. He has no hematuria, and his creatinine is 1.5. So I have really no reason to to do a tonsillectomy, but this is something that I still have a big question mark on. I don't know what's going on. His complements have always been normal. C3 and C4 were never low, which is also kind of atypical for him. I did genetic testing. Of course, he did have a heterozygous mutation in complement factor H, and I emailed Dr. Fervenza because this is at this point is not really known to have any clinical significance because it's a heterozygous mutation, to ask him, you know, I have a case of post-infectious GN. He hasn't really persisted from a hypocomplimentemic standpoint, but his complement factor H has heterozygous mutation, and he thinks this is probably related, but he's not really sure. So that's kind of where we're at. Kind of an interesting case. Bill, every time he runs into me, he's like, are you treating a C3GN guy with CellCept? And I was like, no, he's not on anything, and he's still doing okay about a decade out. So, you know, whether this is a C3GN or it was a case of post-infectious or post-strep GN that got better, and now we're just seeing sort of a stable CKD and happens to have a complement factor H mutation with heterozygous, be a coincidence, I'm not really sure. So this is the best I can kind of put this together.
You know, we've been ordering, all of us have been ordering more and more of these genetic profiles. We always find additional findings, variants of unknown significance, and most of them are things we've never heard of. But in a case like this, when, you know, a factor H deficiency comes up, it seems almost impossible not to see how it's somewhat related, even though it is a heterozygote. And I think that's what you had implied to Dr. Fervenza, and that's what he kind of agreed with you. But who knows? I mean, it just seems like, how could that not be related? Because it's such an atypical case, but then nothing fits. You know, the immunofluorescence, the EMs don't fit completely with anything, with either of them. You know, I remember when I saw this article, and I sent it to you, I can't remember, one was in AJKD and one was, I think, in KI or something, but basically brought up this whole paradigm that chronic post-infectious, post-strep GN may well be a complement deficiency in these adults. That was a real eye-opener to me, and it makes a lot of sense. Bill brought it up as well, and you know, it's been a real eye-opener to me, and I've always kind of remembered that, and I think this may be a really good example of that, that you know, maybe this guy's got somewhat of a complement problem, and yeah, his second hit was this bad infection. Having said that, he got through 2 COVIDs without relapsing. It was never really a relapse, but you know, just because you have a complement deficiency and you have a second hit, or some genetic disease with a second hit, doesn't mean that you're necessarily doomed. A good example is viral infections in APOL1. You know, some patients get collapsing GN and do well, and some of them end up with end-stage renal disease. And so, you know, I don't know. I think we have a lot to learn about this. So Casey asked the question, now that I know he did well, I would have done the same thing, giving cytotoxin and prednisone, which was kind of, I think Praveer asked in the board. And I think it's reasonable. It's hard to argue with success. I mean, this guy had, every glomerulus had a crescent in it, and yet he's, you know, 9 years later, and he's doing actually pretty well on no medication. And it also gets, to me, a little bit back to Dr. Rubin's point about the crescents, that, you know, maybe these weren't all fibrotic, and maybe being aggressive made the difference here. I don't know. Dick, what do you think about this heterozygote? Do you think there's anything to it?
Yeah, Roger, I think I agree with both you and Fernando's suggestion that maybe this patient has a hypomorphic allele, and that in the heterozygous state, his complement factor H levels are not normal. Although they're sufficient without an infection to maintain normal complement activity, when he gets a superimposed infection, he can't deal with it properly, and he gets activation of the solid phase of complement activation, not fluid phase activation, because his serum complement has always been normal, but there is definitely tissue-based C3b activity with complement conversion. Obviously, this raises today the question of eculizumab. In a patient like this, I don't think I would have used it, but and I think the inflammatory component of this patient's disease was handled very well by the steroids. I don't know whether the cyclophosphamide had anything to do with his recovery or not. We'll never know that answer.
Yeah, part of the problem is that we're kind of You know, we came from an environment where crescents pretty much equaled cyclophosphamide, like a little too much lumping, you know, and that was Dr. Lewis's bias. And so it's kind of hard for us to think outside there, to think that just steroids might be enough. But you bring up a good point. Bill, is this your slide?
It is, and I just bring it up because obviously you said 9 years ago, none of this was really available, but the copans, the complement blockers, I think if you have an active C3GN, and I'm not saying that's what this guy has, but if you have one, they need to really be going into a clinical trial. And there are clinical trials of all the different complement pathway blockers along the way that can be very specific and targeted and see if they work. And so CellCept is good if you really have no access to a clinical trial, but if you can do your best to get your patient into one, it's important. We're doing one, which is almost starting to enroll here, but it's not quite active yet, but see if you can get your patient in one.
Casey, if this guy relapsed, would you consider treating him more like a complement deficiency instead of the approach?
Absolutely, absolutely. Yeah. I will send him to Bill to get into the clinical trial.
I'm sorry, that was hysterical. Well, I'm really glad we had this discussion. I'm glad Dr. Glassick kind of agrees, because, you know, I think we have to be careful when we look at some of these things. We don't know everything, and then you get this fancy piece of paper back, and it seems like it's definitive, and it, you know, we're still learning. We're still learning a lot, and you know, it's hard to believe that it was a simple case of post-strep GN, that there wasn't a lot of clues here, but who knows? I learned a new word, hypomorphic allele. So, you know, once again, Dr. Glassick, I've got to go and do my homework and learn a little bit more about something you brought up. And I think with that, we'll end it. Great job, great discussion. Thanks, Casey, great case, and thanks, David and Pravir and Bill and Mario, and of course Dick for contributing so much. We'll be off next week, and we'll be on probably the week after. Everybody stay safe until the meantime. Finally, the activity code, CME activity code is 485990. And until then, stay safe.